Assalamu alaikum, everybody. Can you hear me?
Yes, we can hear you nicely.
Yes, actually, my name is Dr. Zishan Hashmi. I am a consultant anesthesia at King Saud Medical City, Riyadh. Some of the people know me already, and I have been in sort of this taking classes on Zoom for last few months. And before that, I have a group of WhatsApp around now it has grown up to around 13 to 14. And it has a number of people from different parts of the world because the majority of the people who are in touch with me are understanding our native language. So I was not able to start this in international language forum, but this time I just tried to start it. And if anyone else will be interested, we can continue this because I'm doing this daily. Whenever I'm getting time. Okay, so coming back to the our main agenda, which is for the consultant evaluation exam for Saudi Commission. So I would like all of you who are appearing who have the earliest date to just raise them so that I will try to make them my main audience, and the rest of the people can add if you miss anything. Okay. So if the people who have the coming 20 days or 15 days or 1 month, just raise your hands. So I will be focusing on you people more than others. And the other thing, yes, Muhammad Mubarak. Okay, this is one thing. The other thing is that because all of you are in the clinical practice and know the subject of anesthesia very well. So what's the problem which people face in the exam is not that they don't know or they don't know how to perform anesthesia. The problem is that the only issue is that they are unable to focus on the question. Just one request that all of you mute your mic. Okay, mute your mic, and whoever wants to ask any question can raise the hand. And rest of the people, if kindly mute the mic so everyone will be hearing better. Okay, I will try to mute all of you. Yes. So I will start with the point that what is the general concept of this evaluation exam. They just give you a scenario. Okay, like for example, if I just start with a baseline scenario that a 28-year-old female, pregnant, on term, it is presented to you in the pre-anesthesia clinic with the history of peripartum hemorrhage in her previous pregnancy. Okay, and now they have found in that lady to have placenta previa. Okay, placenta previa. So how will you prepare the patient? How will you prepare the patient for the surgery? Okay, this is for cesarean section. Just a second. Who will be volunteering to answer this question? Dr. Mubarak or Dr. Ala? Who would like to answer this question? Whosoever wants to answer, just unmute the mask and we can start.
Can I answer here?
Yes, I can hear you. And just let us make okay, just let us make it a little bit more interactive. Yes, so this is the patient for C-section, placenta previa, previous history of PPH. Okay, so now this is like a high-risk patient, and now because the thing is that they will be asking this question, and you, for practice purpose, you just mark your clock and you will have maximum 4 minutes to maximum 5 minutes. This I am telling you maximum. It will be even less than that. So you have to compile your question or practice in a way that you are able to tell the highlighted points in these only 3 to 4 minutes. Okay. So what will you do? Yes, Dr. Sabir.
For me, if this patient come to me in pre-anesthesia clinic, I will start with her evaluation by history. This history as regarding if she has any allergy to any drugs, or she have any comorbidities, diabetic or hypertensive or cardiac disease. And I will ask her also about if she has any problem. She have anesthesia history, what about the previous anesthesia, and if she had ever in any complication in the previous pregnancy. This is about the history. About investigation. I will check her complete blood picture to check his basic hemoglobin level, coagulation profile, and blood group. Then I will discuss with her the anesthesia plan.
Okay.
Then I will ask for blood booking for this patient, because she is from the history she has a previous attack peripartum hemorrhage, and she is also now placenta previa. So I will write in my anesthesia sheet to book. I will write in my anesthesia.
Just a second, please, a humble request to all of you, please make sure you have your mic mute, okay? Because everyone will be disturbed then. Thank you. Yes, Dr. Sabir, please continue.
So I will ask to book at least 4 units of cross-matched blood for this patient.
Okay.
And I will also I will ask her about if she has signs of aortocaval compression during her pregnancy.
Okay, so actually in real time, what will happen that immediately when you will be telling this preoperative evaluation, he will be asking how will you manage, like what will be your choice of anesthesia and how will you proceed, like because this will be a elective cesarean section. Okay. Yes. So you have all the things which you can arrange in a certain period of time. Maybe this will be after 2 days, after 3 days, after 1 week, whatever it can be. Okay.
Yes.
So because it's
for
an
my
elective, yes.
For this is elective cesarean section. First, I will give option for him. It is better according to ASA to refer to placenta previa center. This is better for here because they have more facilities in their center. For us, if it will be done in my hospital, as I told before, there is anesthetic consideration for the pregnancies that they sensitive to anesthetic drugs. They have aortocaval compressions. They have cardiac output. They are easy to desaturate. Also, they have element of difficult airway and full stomach because of delayed gastric emptying. This is about the consideration of the pregnancy. About consideration of the comorbidities, this is patient is placenta previa and have a history of peripartum hemorrhage. This is high risk to have massive hemorrhage during the operation. So we are prepared by blood products. We have these warming devices. We will insert 2 large bore cannula. We'll be ready also with vasopressor.
Okay.
For anesthesia consideration, we will start by general anesthesia to avoid sympathectomy. Because if bleeding happens, it will be more decrease in her blood pressure, because bleeding can happen immediately just during the extraction of the baby or the placenta.
Okay. So just I will interrupt you here. Have you noted down the time you have taken? Have you noticed the time have you taken? And up till now, you are only in the middle of the surgery. You are not even able to deliver the baby. Am I right?
Till
So
now.
what's the issue? That's the issue. You know, you have told everything perfectly, but now in the real time, when you will be telling in detail, the examiner of the Saudi Commission exam will be looking at you like he is about to eat you. Okay, he will be becoming angry. Okay, so I will just try to tell you how you will be able to tell the same things, but with little words, so that you are able to save the time, because this patient has to reach from the anesthesia clinic up to post-op. Okay, and he is ready to listen to everything even without interruption. If he's you are telling the points. Okay, and difference between any other exam, for any other academic exam and the Saudi Commission exam, is they are really not interested to listen any academics. Okay, they are not happy if you are telling them some pathology or some very detailed, fine, minute, microscopic, molecular level thing. They are not interested. Okay, they are only interested to they only want you to make a consultant who can easily handle the pressure of the patient management as well as the pressure of the multidisciplinary team. Okay, so your answer will be that I will evaluate the patient according to history, examination, and relevant history, examination, and relevant investigations, and I will be involving the multidisciplinary team which may be needed in this patient in the form of ICU. This patient will be needing ICU, post-operative ICU. This patient can bleed like anything, and even if it is placenta previa, this can be misdiagnosed in the form of, like, because this patient has history of previous peripartum hemorrhage. So I will be looking that maybe this can lead to the similar picture with the placenta accreta or percreta. Okay, so I will be taking on board the surgical, urology, and interventional radiologists to put a balloon or they should be on board so that they can intervene in the management of the patient if the patient bleeds like anything. Okay, this is one thing. Then you will be taking on board the blood bank and pathology to have the blood and blood products ready for these patients, because this patient can need a lot of blood products from PRBC, FFPs, platelets, cryoprecipitate, and even this patient might be needing factor 7 and thrombolytic therapy. So okay, so this is another thing. If this patient is having preoperative anemia, you would like to treat the patient sometime, like build up the hemoglobin in a way that you are able to, this patient is able to tolerate the bleeding in the perioperative period. So if it is hemoglobin is low, you will build up. Okay, and you will, like in this patient, you told that you will be focusing on the previous history of any medical. So you can say this in one word by saying, I will take the patient demographic according to age, sex, location, previous medical or surgical or anesthetic history, any point if I get extra. This is in 1-2 words you can say this, because in this scenario their main focus is not to take you history of that patient. Okay, and then you will say that this is a pregnant patient, so I will be focusing on the altered, you just note down this word, altered physiological, I will write it later on, altered physiological, pharmacological, and anatomical consideration in a pregnant patient, which will which will result in modification of our anesthesia plan. Altered physiological, pharmacological, and anatomical considerations in pregnant patient, which are warranting the need of change of our anesthesia plan. And there are 2 lives. So you will be taking on board neonatologist and like preoperative CTG, to see the status of the baby. Okay, so this will be like covering everything which, and then you will be informing the operation theater staff that we will have a patient who is at risk of massive bleeding. So you will be trying to maintain all the factors which can increase the bleeding, or all the factors which will be helping to reduce the bleeding and increase your chances of survival of that patient. Like what will be those factors? Maintaining the temperature of the room. You should have, if possible, you should have cell saver. You should have massive rapid infuser system. Okay, you should have when the patient is in, you will be anesthetizing real time, you should have 3 to 4 big size IV cannulas. You should have invasive blood pressure monitoring. CVP is not clearly indicated, but you can say if you want to monitor the fluid status, if needed, we can do it. If you have good size IV cannulas and rapid infuser system along with this cell saver, maybe you don't need it. Okay, and then you will be needing to evaluate in case of bleeding if you have the availability of rotum or thromboelastography. Because yes, you can give the replacement in the form of hemostatic management, but it is better if you have the facility, you can say the thromboelastography. Okay, thromboelastography or rotum guided fluid replacement. Okay, so you will be preparing the operation theater for possible any possible catastrophe which you will be facing during the conduct of anesthesia for this patient. Okay, so because you have to tell these things preoperatively, so if you take few minutes now, if I summarize it, I will say I will have a multidisciplinary team involving the surgeons, the urologists, the intervention radiologist, and the operation theater staff to prepare the things which may be needed for this patient, and the arrangement of the post-operative ICU. This in few words you will say everything, and some of the things are common for any trauma patient, except for specific like doctors which we are needed in this scenario. Some of the things regarding the cell saver, thromboelastography, rapid infuser system, large bore IV cannulas, this thromboelastography you can tell in any bleeding patient, which you can be asked in this exam in the form of like aortic aneurysm or any bleeding patient. The same things you can say in those patients as well. Okay, so this is what you will be focusing, and then you will be saying, of course, the choice of the anesthesia will be general anesthesia, and you will be avoiding the factor which can increase or cause uterine relaxation, because that will increase the bleeding. Okay, so you can say that you will try not to use high MAC. You can the MAC should be low, and you will be needing oxytocin, methergin, prostaglandin, PGF2 alpha, and Novo 7, factor 7 if nothing is working. Okay, and they will be using some surgical maneuvers to stop the bleeding in the form of Billinch, massage, and they should be taking the consent for hysterectomy pre-hand. This should also be told in the preoperative assessment portion, like preoperative preparation portion, that you should have it will not be your responsibility, but as a multidisciplinary team you should have the indication for its consent for hysterectomy if it is needed. Okay, so that's how you will be telling in the real time in this exam. I have tried to tell you all the things. Now you can think that if you use meticulous words, you will finish this scenario in 3 to 4 minutes. Okay, because you will be giving the target, you will be preparing the patient, all the teams required, or everything which is needed in the operation theater. You will say that I will prepare this, I will prepare this, I should have 4 to 5 units of PRBCs and blood products in the room when we start the case, because this patient can bleed like anything, uterus has very high blood flow, and blah blah. Okay,
Okay.
Anyone wants to add something in this scenario?
Yes, they asked the question in this scenario. They asked the question, if you are in not equipped hospital, as Dr. Sabr said, and they want, and you are preparing the patient to be transferred to a tertiary hospital.
Okay.
What you will give her?
What you will give her to that patient? Actually,
Yes.
this like you, because you know, in this question can be asked in an emergency scenario as well. The same patient, like you face it in emergency. Okay, so you will say that we will have a multidisciplinary team discussion. Okay, and we will try to find out the maximum and safest possible way. If that case be not be done in the hospital in which you are working, you will discuss with the hospital management and the surgeon, and you will try to shift the patient where they have better facilities. In the what they want to ask in this question, which I can guess only, that they only want to have, you can take some IV fluids, you can start like you can take some large bore IV cannulas and you can start some fluid. That's it. I don't think so anything else you can do.
There is something else, doctor. They want to hear the tocolytic. They want to hear that you will give something to relax the uterus to avoid delivery during the transfer of the patient.
Yeah, you are absolutely right. But actually, you are absolutely right. But usually what if you are in habit of involving any multidisciplinary team, okay, tocolytic you will be using if the patient is in labor, okay, or patient can go in labor. And you are absolutely right that these this thing should be in your mind, okay. And the tocolytic which you can use is like magnesium or nitrates or calcium channel blocker, or salbutamol, whatever they want to give, because this will not be your decision. Okay, this will be according to the this one obstetrician. Am I right?
Yes, you are right.
Okay.
Also another point about the using of cell salvage, cell saver during this surgery. They want to hear from you also, because they asked this question directly.
Yes, I told about cell saver, and regarding the use of cell
saver, there is some precautions for this cell saver in this patient.
Yes, you should have two suctions, okay, one for the amniotic fluid and one for the clear blood. This is one thing, and they have some filters which will filter the amniotic fluid.
Leukocytic filter,
yes. And another point is that which you should be using in all your answers, that you will always use the word risk versus benefit. Okay, use the word risk versus benefit. You have to behave like a politician, in the sense that you are giving the answer which is covering both the sides. And if you feel that the examiner is wants to listen something else, you can change your statement. Am I right? So you have to behave like actually a politician. Okay, so this scenario actually covers a number of things which are being used in other scenarios. Okay, so I will tell that other blood conservative strategies which you can use in addition to, usually you can do it here as well, that is hemodilation. Okay, you can, before the start of the surgery, according to the situation, according to the heart status, according to the scenario, you can say that you can do some normovolemic hemodilution or hypervolemic hemodilution. Normovolemic hemodilution is you extract a unit of blood and replace it with 3 or 4 times of Restylide or 1 equal volume of Colite. This is one way. Or if you have a patient which is having rare blood group, or if a patient which is expected to bleed, you can reduce the effective circulatory RBC loss by diluting the blood. Okay, and diluting, you can do it on the spot by removing 1 unit of blood and replacing it, or you can save his or her blood in the blood bank preoperatively over a period of time, maybe a period of months. You can store the same patient's blood and give it if the blood group is rare. Okay, so this is an extra point which you can say. And correction of anemia, like you can, if there is a patient which is suspected to bleed and patient is anemic, so you can refer the patient to hematologist to find out the cause of bleeding, cause of anemia, and correct it in the form of iron deficiency anemia or folic acid deficiency anemia or any surgical or medical correction which is needed. Okay. So like this is actually we in this one scenario, we have discussed the blood conservative strategies, correction of anemia. And in anemia, you will be seeing that effects of anemia is in the form of like enhanced cardiovascular stress response, and patient is having high cardiac output, patient is tachycardic, body is trying to conserve, body is trying to compensate for the reduced hemoglobin by increasing the cardiac output to increase the oxygen delivery. But at the end of the day, it is in the form of compensation, it is also actually heart is sinking down gradually. Okay. Because heart needs to contract more and more, but there will be hypertrophy. Okay, there will be increased oxygen demand and reduce oxygen supply, because increased heart rate affect both delivery as well as increasing the requirement. Okay, so this is, and one thing I missed to tell you, during intraoperatively, in addition to oxytocin and methergin and PGF2 alpha, misoprostol, Novo 7, factor 7, if it is indicated, they can also use antifibrinolytic like tranexamic acid. Okay, so this is all. And if they ask the same question in emergency, you will not tell that we will, because you don't have time. Suddenly you will activate, they want to listen the word, I will activate massive transfusion protocol. I will activate massive transfusion protocol, and I will, they will ask what is massive transfusion protocol. It is like a hospital-based protocol in which they have already prepared like O negative or O positive set of blood PRBCs, FFPs, platelets, that if, for example, there is sudden bleeding and there is no time for cross match, they will immediately bring it. Okay. And the composition can be different according to different hospital. But the main protocol, the main rationale is to have the survival of the patient immediately by giving the blood. Okay, so this is what is massive, because they want to listen massive transfusion protocol in this scenario. Okay, so any question about this scenario? Any other thing which we have missed? Anyone wants to have any comment?
Please.
Anything?
Patient with placenta previa.
Yes.
And they told you, blood bank told you that we have only 2 units. It is elective CS. Placenta previa, you have only 2 units of backed RBCs. What is your decision?
Yes, you will refer the patient to a place where there is blood. If this is elective, you cannot proceed with 2 units of PRBCs in a patient in which you require massive blood transfusion.
Then they told you surgeon insisting to do the surgery. They didn't enter into that it is emergency, still elective CS.
Elective, you know, Dr. Sabir, in elective, you will say that you can involve the hospital administration and you can have a multidisciplinary team that this is, look, this is the problem. We can face this issue. And if there is no other way, or for example, there is no other facility they can refer, then you have to do it. Okay. Or the facility. Yeah. So you can say that it will not be your decision to cancel, or it will not be only your decision to proceed. You will have a multidisciplinary team outweighing risk versus benefit, and then there will be a common decision for the betterment of the patient. Okay.
This sentence, يعني, should we mention that we should refer to placenta previa center, or we shouldn't mention this?
Actually, don't take it on your shoulders. Say that we will have a multidisciplinary team, including all the involved people, to decide what is the best. This answer is safe.
Yeah.
If you take it on your shoulder, okay, they can ask you that they can ask you some further question. Okay. But if you say that you will have a multidisciplinary team and they will be considering all the elements and then they will decide, so you will be safe medically, am I right?
I told my colleague like this, we should include the medical director, head of department, This is no issue.
If you just, because I told you that you have less time. So if you can say that hospital administration, it
multidisciplinary bleed.
Hospital, yes, multidisciplinary team involving all the concerned people, hospital administration, surgical and anesthetic team, and then they can decide. Okay, and the patient has relatives as well. They should be involved. They should be involved. Okay. So this is what they can ask any maximum about a bleeding patient for placenta previa, placenta accreta, placenta percreta, like any cause of antepartum or postpartum hemorrhage. They can ask the similar question slightly different in a way that they can ask you a maternal collapse scenario. Okay. A maternal collapse scenario. So who would like to tell Dr. Sabir? Anyone else want to answer this question? That you have a patient in a preoperative in preoperative ward, labor ward, okay, and this patient was having labor epidural in situ. Patient was comfortable, and suddenly patient you received a call that patient is collapsed. Okay. So what will you do? How will you proceed? How will you manage? Yes. Yes, Dr. Taha. Yes, Dr. Taha, would you like to tell? You are mute actually. Can you unmute yourself?
Yes, in this scenario, it's very emergency and critical scenario.
Okay.
So I will, my approach to started with ABC.
Okay.
Management the airway, management the breathing and the circulation, and the disability of the patient, like trauma patient.
Yes.
I will inform the all multidisciplinary team. This patient will critical. If patient need intubation, I will prepare for intubation. I will check all vital signs for this patient. I will inform the surgeon. We have very critical in the ward, pregnant woman maybe need for urgent or emergency intervention.
Okay, I will just interrupt you for a second. This patient had a epidural in situ. Would you like to do something for that?
She's in beltless epidural.
Yes. So what would you do?
I will check the vital signs first. Maybe this is effect of pharmacological effect of local anesthetic. I will see maybe another effect of intracellular hemorrhage, bleeding, internal bleeding. I will check about toxicity, about local anesthesia toxicity. All these things to be considered.
Okay, so I will just add to what you have told, that in any scenario like that, you will say immediately, you will use the word call for help. Call for help.
Yes,
and
yes.
You have to remember this thing, that if this scenario is for local anesthesia toxicity or malignant hyperthermia or embolism or everything, you remember the word stop.
Yes.
Either you have to stop the surgeon, either you have to stop the medicine, either you have to stop any, like, you remember this word stop. So in this scenario, you have to stop the epidural because this may be the cause. Okay. So you have to stop it. And regarding what you are saying, airway, breathing, circulation, you have to elaborate a little bit, that you will immediately see whether the patient is conscious or not. And you will make sure patient airway is patent, patient is breathing well, and patient has good IV lines, IV fluid going, and have the blood pressure. Like you will, as I have written here, management, resuscitation, and evaluation will go side by side. You will use this word. You can use this word in any critical incidents. Remember this word. For example, I have written the word here, stop. So stop is for anything. Like if the same question they ask you for possible malignant hyperthermia, you will stop the inhalational agents. Okay, you will.
I will
remove the machine.
I will diagnose and manage simultaneously.
Yeah. So you remember this word. Resuscitation, management, and evaluation will go side by side. And another thing which I will write here, anesthetic factor.
about the behavioral
patient factor, surgical factor, and here obstetric factor. Okay, so it is called as classify or die. If you don't classify, you will die. Okay, so if you remember this approach, that whatever you are telling, maybe you don't need to utter the word anesthetic and patient and surgical, but it should be in your mind that what is the possible differential diagnosis. Anesthetic factor you will rule out, that the patient, as you are telling, that patient can have patient may have total spinal or high spinal, or patient can have last local anesthesia.
Something happened, migration of the catheter in the intrathecal space, maybe sometime happened.
Yes.
So with high spinal to affect the vital signs of the patient.
Okay, so you see any other factor, like patient can have any cardiac cause, respiratory cause, endocrine cause, metabolic cause, neurological cause. Okay.
Yes, all causes maybe which happened with cause the collapse of the patient.
Yes.
All disease. Yes.
All and this is again I'm telling you because maybe for discussing all the scenarios, maybe it is difficult, but you people are all smart and mature, and if I only give you the trick that how you have to answer the questions, for this is in this way I'm telling you to answer any critical incidents. I will immediately stop the surgeon. I will immediately call for help. I will immediately try to have approach of airway breathing circulation. I will make sure patient is having patent airway, patient is breathing or not. If not, I will put oxygen mask, or I will make the prop up, and I will attach the like if patient's airway is not patent, I will maintain with definitive airway. I will make sure patient is having good blood pressure, or if not, I will start fluids, and I will start any vasopressor or inotrope according to the situation you can say. Okay, and then I will immediately do the ABGs to see what is the homeostatic condition. Okay, maybe you have any.
Yes, this scenario is similar in the patient in the ER.
Yes, similar, like
closely similar. Yes,
like what can be the
like ATLS protocol, flow like ATLS protocol for ABCD.
Exactly.
Yes,
exactly. And what about the obstetric causes? Obstetric causes can be what can be the obstetric causes of maternal collapse?
Yes, obstetric causes, many obstetric causes like placenta previa, placenta accreta, increta, postpartum hemorrhage, amniotic fluid embolism,
very good,
pulmonary embolism, everything.
Now uterine rupture, uterine rupture, abruption. Okay, and you have missed one thing. The mother of all our obstetric anesthesia, the eclampsia. Okay, patient can have eclampsia and patient will be unconscious. Am I right? That will be like you at that time you are being called, patient is not stable, you don't know what is happening. Okay, and then on the basis of in the evaluation you can say that you can.
Yes, I think my major action for this scenario, like anesthetist, to diagnose and manage simultaneously, to don't lose any time for the patient. If patient is collapsed with hypoxia, I will survive this patient with oxygen delivery. I will discuss what the hypoxia exactly to see. Imbalance between auto delivery and oxygen demand. How to manage this scenario exactly with securing the airway. This is the very important for in this point. It's measure my rule like anesthetist.
Yes. So further management will be guided according to the findings which you will have. Okay, if there is, for example, if there is a patient is collapsed, patient is having a bronchospasm,
according the cause.
Yes, maybe patient has some redness, patient has some so maybe your diagnosis will be going towards anaphylaxis. Okay, so you will be giving sending the sample of tryptase, you will be giving epinephrine, and you will be given the same
Yes.
fluids
Anaphylactic
and vasopressor.
shock reaction.
Okay. If, for example, it is going towards any embolism, you will have decreased cardiac output, you will have hypoxia, patient will have no, and then you will be intubating the patient and starting management accordingly. Okay. If it is yes, if in any
or in
yes, one thing you will be telling that if it you will start CPR if patient is collapsed, and one thing in this scenario you have to mention, very important point, but will you not forget, is
yes. If the patient is
lateral position to avoid aortic compression, and after 4 minutes, if patient not responding, will deliver the baby.
Yes, thank you. This is the
within 5 minutes. Within 5 minutes.
Yes, within like you have to do early cesarean section. It is like a peripartum cesarean section. It can save the life. Okay.
I remember like this scenario. It's happened in the Jordan before 10 years when I was resident.
Yes.
This patient is the same scenario in the AR with collapsed patient. We are activate the multidisciplinary team, and the patient intubated, start CPR, and without any taken for sterility for this patient, the patient is start cesarean section, and we are saving the mother and the baby. Sometimes no time permit to transfer the patient to the OR.
Yes. So yes, you understand this. And what will you do, for example, if in the same scenario, if you check the blood pressure was 220 by 100, what will you do? As in the same scenario, patient was collapsed, nobody witnessed the fits, but maybe patient was unattended, and maybe the patient had fits. So what will you do in this scenario?
This scenario for severe preeclampsia.
Preeclampsia or eclampsia?
Or eclampsia, yes.
So what will you do?
We will try to with approach of my approach for I tell you ABCDE. If the patient is with high pressure, I will try to decrease the blood pressure. I will give magnesium sulfate. I will give antihypertensive drugs to try to prevent the secondary brain effect. So
for this question, they will ask you which medicine and how much dose. So which medication and how much dose?
In this scenario, that it's I will start with the magnesium sulfate, 2 gram IV, bolus dose.
Okay.
After that, we will start it with infusion of 1 gram per hour.
Okay.
From 1 gram to 2 gram per hour.
Okay.
And we'll ask for magnesium toxicity every 3 hours.
Very good. So they can ask you that you make your habit that whenever you are telling magnesium, about magnesium therapy, you can say that you can have the baseline magnesium level and baseline any clinical signs of magnesium toxicity, and then start magnesium. And according to what you are saying, that 2 gram stat, and then infusion according to the respiratory, deep tendon reflexes, urine output, cardiac signs. Okay. And
this patient need to admitted in the ICU after this scenario.
Yes.
To controlling, to monitoring the toxicity.
Yes.
Of magnesium sulfate.
So what else? What else you will do? Blood pressure for reducing, in addition to magnesium.
Another drugs shows the hydralazine with the boluses dose of 5 mg. With maximum dose of 30 milligram.
Okay.
We can give labetalol also for this patient. We can give hydralazine also.
Okay. Like they will ask you small doses of this in this scenario. Because most of the things you will be having the same. The main aim in this scenario will be control and prevention of fits, control or prevention of fits, control of blood pressure, and delivery of the baby. Okay. So after controlling the airway, breathing, and circulation, you will discuss with the obstetrician what's their plan. If the time, if according to the gestational age and condition of the patient, that you will decide according with. It will not be your decision, by the way. You will say again, use the same word, that according to risk versus benefit, they will decide whether they have to proceed with the pregnancy or deliver the baby via cesarean section or initiation of the labor. Okay, this will not be your decision, but you will tell that you should focus your answer by 3 words: control of blood pressure, control or prevention of fits, delivery of the baby. Okay, and additionally you can say that yes, in the same scenario you can add also that if patient is uncontrolled blood pressure, you can have assessment of end organ damage in neurology or cardiovascular, because this patient can have myocardial ischemia, this patient can have cardiac failure, or this patient can have pulmonary edema, or this patient can have any neurological involvement in the form of raised ICP. Okay, so this will be your
sometime coexisting disease, maybe pheochromocytoma.
Yes, maybe. You are right. You are right. That's what you know. Remember, this,
we will be aware about all
pre-existing disease. Remember this thing which I have written here: anesthetic factor, patient factor, surgical factor. If you remember this scheme in your mind, you will be able to handle the question. Okay, and then they can ask you which will you give. For example, if this patient had an epidural in situ, you can, when after evaluation of the patient and patient is stable, you can only give the dose via epidural. Don't need, if the patient, you have time, you can just top up with the epidural dose for surgical anesthesia, and you can proceed. If the patient does not have epidural, then you have to discuss and you have to evaluate whether you want to give general anesthesia or regional anesthesia. Okay, advantage of general anesthesia will be that patient's airway will be secured. You can control the hemodynamics in a better way. This is the advantage. You can. The disadvantage that the patient, pregnant patient, like any other patient, has difficult intubation, difficult airway, risk of aspiration, and you are giving the hemodynamic stress response. So you have to manage the hemodynamic stress response. You have to give the aspiration prophylaxis. This one you will tell, and in the form, if you are giving epidural or spinal, you will say that you have to rule out any coagulopathy at the moment or any impending coagulopathy. Like this patient may be having normal platelet count or normal INR, but maybe this patient can bleed and this patient can go in any coagulopathy. So if you want to defend your answer in the general anesthesia, you can say that if I have any doubt about coagulopathy, I will not go for regional anesthesia.
Yes, I will go for GA. Yes.
Yeah, and I will.
If I have concern.
Yes, I will stratify the risk by having invasive blood pressure monitoring, and I will control the stress response by giving fentanyl, by giving short-acting beta blockers, or a deep plane of anesthesia. Even if I need to give opioids, I will inform the neonatologist that this patient was having
and lidocaine.
Yes,
don't forget lidocaine.
Lidocaine, yes, lidocaine IV or lidocaine spray. Like you will say that I will control the stress response, but for this patient, if I have any doubt, and another reason is that this patient can have exaggerated blood pressure fall because of the pathology of PIH, eclampsia. The patient is having low blood volume. And if you are giving regional anesthesia, patient blood pressure can fall significantly, or there are more chances of any bleeding in the form of any coexisting problem. So if you are suspect of any bleeding, then regional anesthesia is not as good choice as general anesthesia. Okay, and if you want to compare between epidural and spinal, so advantage of epidural will be that the hemodynamically stability will be more as
more stability,
but the problem will be the chances of epidural hematoma will be more as compared to a spinal needle, because the spinal needle is a small bore and the epidural needle is big bore. So like this is the the bouncers, this will be the counter questions which they can ask you when you are facing. So it is, if you ask me, don't go for regional unless they push you, okay? Because in exam, practically whatever you want to do, this is not the practical conduct of anesthesia. They will not ask you to give the anesthesia. So it is easier to defend general anesthesia than regional, okay? You can have better control on the hemodynamics, okay? This is my suggestion, but you can say epidural or spinal. There is no clear, actually you will use the word risk versus benefit. Patient choice, surgeon's choice, and according to, it will not be a generalized approach. It will be an individualized approach, okay? If you give GA, this will be the problem. If you give regional, this will be the problem. You have to anticipate accordingly, okay? If the patient is receiving any anticoagulants, you have to regulate and control anticoagulants accordingly. Like if you want to give spinal or epidural, you have to stop the anticoagulation, and you will start anticoagulation after surgical hemostasis. And if still epidural is there,
this is the management of yes, I know
management. So you have to mention this point as well, because pregnancy is a hypercoagulable state, and sometimes the patients have to receive anticoagulants. So when you are giving regional anesthesia, epidural or spinal, you have to consider this thing as well, okay? So this is all what you can be asked regarding like obstetrics, because one question will be for obstetric. We just started with placenta previa creta, and when in emergency, in elective, then we discussed some words about eclampsia and preeclampsia, and then the maternal collapse. If there is chances of like local anesthesia toxicity or high spinal or epidural, you will stop, you will evaluate the patient and your resuscitation management, and then you will come towards the diagnosis at what actually happened, okay? Because sometimes you will not be able to identify the exact cause at that moment, and your approach will be generalized: hemodynamic support, airway, breathing, circulation, and further management according to the cause and according to the findings which you get, okay? So some other questions which they can ask you is at, like, you are a pregnant patient for any surgery, okay? Pregnant patient for any surgery. So what will be the requirements? Any surgery. So you will be using the same word which I told you, that considerations will be altered physiological, pharmacological, and anatomical consideration in a pregnant patient. Presence of 2 lives.
No need to discuss with detail and this.
Yes, only this one.
Because sometimes we have no time.
No, yeah, but the thing is that if you use this word, actually you are telling the examiner, that you know that this is a different patient. This is not the normal patient, okay? And mind it, the same word you can use for elderly. Altered physiological, pharmacological, and anatomical considerations in pediatric patient. Altered physiological, pharmacological, and anatomical consideration in obese patient. Altered.
The same word
same word. This is a beautiful word, just like starter, okay? So they will be coming to know. So this is the consideration, and then you will say considerations related to the surgery, okay? Considerations related to surgery. For example, this is laparoscopic surgery. So the concern will be of laparoscopic surgery, and they will be inflating. So so you have to maintain relatively less pressures, okay?
Okay. Doctor, we have just a small mention for surgery in obese patient and pregnant patient related to obstetrics. We can divide these surgeries. If it is elective, it is should be after delivery, after 6 weeks post.
Yes, I was about to tell you, Dr. Saber, that whenever there is a scenario, I will tell you a trick. You will evaluate any patient in that thing, not only pregnancy. So what are how will you will see the urgency of the surgery? Like if it is emergent, because in the exam, actually in the books, actually emergent and urgent, they are written simultaneously together. Like they don't differentiate, but actually emergency surgery is a surgery which has to be done within minutes. Emergency.
we'll take as a multidisciplinary plane. We'll discuss with the surgeon and the obstetrician. Surgeon, if it is feasible to delay this surgery. No, it is emergency. So it will be multidisciplinary team.
Yes. So let me just tell you about difference between emergent and urgent and planned and elective. There is a little bit difference. Emergent surgery is the surgery which has to be done within minutes. For example, the example is emergency cesarean section. If there is fetal distress, you cannot wait. So this is emergency. You have a firearm. You have a firearm injury or any trauma in which patient is bleeding. This is emergency. You cannot delay. Okay, you have an incarcerated, a gangrenous hernia. Okay, you cannot delay it, because if you delay it, it will increase the mortality morbidity. You have an ischemic limb in which there is gangrene. If you delay it for more than few minutes, like you have to do it within an hour. So that will be actually, in real sense, it is emergency surgery. Now comes the next one. This is urgent. Actually, we use urgent surgery as emergent surgery. Like appendix, we say emergency appendicectomy. Actually, it is not emergency, it is urgent. Like you have to do it within few hours. Am I right? It similarly is intestinal obstruction. This is urgent surgery. You cannot delay for more, but you can have some optimization of the patient. Okay. So, and then the next terminology is planned versus elective. So, for example, the example for planned surgery is elective cholecystectomy. We always say elective cholecystectomy, but actually, if patient has cholelithiasis or cholecystitis, this is not elective surgery. It has to be done. Yes, you have some time. You can give some antibiotics and control the acute phase, and as soon as it is passed, you can do it. I'm just explaining to you the concept. Elective surgery only are cosmetic surgeries, joint replacement surgeries, okay, in which there is no compulsion to do it. There is no, like bariatric surgery, they are elective surgery. Cosmetic surgeries, they are elective surgeries. Joint replacement surgeries, they are elective surgeries. Okay, any corrective surgery, they are elective surgery. But usually, you don't differentiate it. So, but you should be knowing that what is the concept of emergency surgery. Emergency, real emergency, which you say in different hospitals, they use a different word. Sometimes they say E1. So E1 actually is the real emergency. Okay, and E2 is actually urgent surgery that they have to do within few hours. So this is, so whenever they are discussing any surgery, you have to see whether the surgery is emergent surgery, urgent surgery, planned surgery, or elective surgery. This is one concept. Other concept, number two, is what is the risk of the surgery, that whether the surgery is high risk, whether the surgery is intermediate risk, whether the surgery is low risk. So what will you say? For example, high risk surgery are like, for example, high risk surgeries are like, for example, vascular surgery, liver transplant surgery, okay, emergency surgery in an elderly patient. These are high risk surgeries. Okay, liver transplant, like total cystectomy. These are the surgeries which are high risk surgery. And then comes the intermediate risk surgery, like body cavity surgery, intrathoracic surgery, intra-abdominal surgeries, and then renal transplant. Okay, these are intermediate risk surgery. Then there are few low risk surgeries. Head and neck surgery also comes in intermediate risk. Okay, and then there are low risk surgery. For example, incident drainage, breast surgery, like hernia surgery. Okay, so these are low risk surgery. So whenever you are asked for any scenario, you evaluate whether this is high risk surgery or intermediate risk surgery or low risk surgery, whether this surgery is emergent surgery, urgent surgery, elective surgery, or planned surgery. Okay, so these are the 2 points. I'm sure you are clear. Then you will see which position the surgeries has to be happened, like patient, whether the patient's surgery is occurring in lithotomy position or prone position or supine position or Trendelenburg position or reverse Trendelenburg position or jackknife position, whatever position you have to think, because your answer should cover that position, the concerns related to the position. Okay, then you should be thinking that any critical step which is occurring in that surgery, or any specific precaution you have to do. For example, if they are doing abdominal aortic aneurysm surgery, there is a critical step is the clamping and unclamping. Okay. If any surgery, there is tourniquet, this is a critical step. When they are putting the tourniquet and when they are releasing the tourniquet, this is a critical step. Okay. When they are having any, like for example, laparoscopic surgery, the point when they are inserting the trocar, this is a critical step. In this step, there can be bleeding, there can be injury to viscera, there can be severe, like any response. The other second step in laparoscopic surgery is pneumoperitoneum, creation of pneumoperitoneum. When they are creating the pneumoperitoneum, this can cause a hemodynamic effect. This can cause basal stimulation and patient can go in bradycardia. This can have like a hemodynamic effect. As I told you, venous return can decrease and patient can collapse. So in any surgery, just when they have told you a surgery in your data, think, scan your brain. What is the risk? What is the urgency? What are the critical steps? What are the position? And then the duration of the surgery. Because duration of the surgery, if it is more, there is more risk of certain things. Okay. There is more risk of pulmonary embolism. They are like prolonged anesthesia. So duration of the surgery is important. Critical steps in the surgery is important. Risk, I'm repeating it just so that you memorize it and you don't forget. So any surgery, you just chalk out in that way, because according to these points, you will have to tell. Okay. You have to tell, like, for example, if we take the example, if someone told you about TURP, so they will only tell you the TURP and your brain will be scanning. This surgery will be in lithotomy position. They will be using the fluid. So this fluid can be absorbed. This fluid can cause TURP syndrome. This fluid can, if it is cold, patient can go in hypothermia. This patient is old age, so there are chances of more comorbidities. Okay, things like that. So this patient, when I'm giving regional anesthesia, bladder can be perforated. This patient can have this obturator reflex. This patient is an old age match patient, so post-operatively there are chances of patient going in delirium, like things like that. I'm just giving you an example. So you will just try to focus the urgency, the risk, the critical steps, the important points about that surgery. And yeah, you can just chalk it out. You can just program this and plan this before time. Okay. So this is default for any surgery: laparoscopic surgery, hernia surgery, breast surgery, orthopedic. Yes, for orthopedic surgery, critical points are, for example, the chances of patient having pulmonary embolism, chances of patient having fat embolism, chances of patient having severe pain in positioning. Even this is a concern. Patient may be using tourniquet. Okay. Patient may be like whenever there is one fracture, you have to rule out any other polytrauma. So this should be in your mind. Even if they have only tell you that there is a patient with femur fracture, at least in your answer, you should be covering that you have to look into any other associated injuries, because usually it can be isolated, but usually if it is occurring in trauma, you have to rule out the other comorbidities and other systems you have to rule out. Okay. So similarly, ENT surgery, there are chances of throat pack. There are chances of bleeding. There is chances of trauma to oral cavity and mucosa and everything. Okay. And then there is shared airway. Tube can kink, tube can dislodge. Okay. And there is chances of, like, for example, if there is a nasal surgery, they have closed by packing the nose post-operatively, patient can have airway obstruction, because if they clench the teeth, and if the tongue fall, there can be airway obstruction. Okay, so you have to counsel the patient preoperatively. Then when the surgery will be finishing, you have to breathe through your mouth, because your nose will be closed. So this is the concept. Even the throat pack in, throat pack out, like retained throat pack, and even the problems which are associated with the placement of throat pack. This is a trauma. The patient will have more sore throat, more pain in throat post-operatively. Okay. Then if you just focus on like ear surgery. So in ear surgery, you have to avoid, in certain surgeries, you have to avoid nitrous oxide, because nitrous oxide can create problem in the, if they are doing tympanoplasty or something like that. Okay. Then similarly in mastectomy, they are monitoring the facial nerve. So whenever, if they will only asking you, the surgeon is doing mastectomy, they will not tell you anything. So you have to keep in your mind that mastectomy or parotid surgery or thyroid surgery is one of the surgery where they have to monitor the nerve. So whenever they are monitoring the nerve, you have to be careful, and you have to avoid muscle relaxation, because you can have the initial intubating dose of the muscle relaxant, but you don't have to repeat it, because if you repeat muscle relaxant, they will not be able to identify the muscle contraction, because so you have to give TIVA, or you have to use any alternative technique or any alternative mechanism with which you will maintain the patient knockdown without muscle relaxant. Okay. Yes. Okay. So in ENT surgery, I have told you these concerns. Like in ear surgery, there is more chances of post-operative nausea, vomiting. So whenever they are telling you mastectomy or any ear surgery, make up your mind that you have to give extra prophylaxis for post-operative nausea, vomiting. Okay. So maybe the way of preparing is looking a little different to you, but believe me, it's very effective. That you target the surgery, target the patient in that way that you make up your mind before exam. You don't need to think at that time that there will be certain things related to specific surgery. We have discussed about orthopedic surgery. We have discussed about ENT. Okay. Similarly, whenever there is involvement of vagus, the vagabond nerve, there will be chances of patient going in bradycardia. There will be chances of increased chances of post-operative nausea, vomiting. Similarly, if, for example, you have only cervical dilatation or any anal procedure, okay, in that, where they are giving the anal dilatation or cervical dilatation, or eye surgery. In eye surgery, similarly, there are chances of patient going in bradycardia because of vagal involvement. Okay. So in any surgery in which there is involvement of vagus nerve, there the patient can go in bradycardia. Similarly, I told you before a little while ago, pneumoperitoneum. Whenever they are doing pneumoperitoneum, patient can go in bradycardia. Okay. So these are the points which you have to remember, because this will be asked during your exam. Okay. So coming back to, so these are the points you have to extract through the surgery. Like whenever they are telling you any name of any surgery, scan your mind through this, which I have told you. You understand? And any query, any point need to be clarified?
For emergency, yes. With fetal distress, which best option, spinal or general anesthesia?
You have to choose between fetal distress and the discussion with the surgeon. Okay. Usually, if you in the exam, if you say general anesthesia, that will not be a wrong answer. Okay. If you see spinal anesthesia, maybe if they are saying you fetal distress, that you can say that we will discuss with the surgeon how much time we have. If you can manage to position the patient and proceed, you will do. Otherwise, it is not advisable to delay.
Yes, exactly. We refer to the obstetrician that he say مثلا emergencies. If it is, I told him there is time to give spinal or GE. He say خلاص GE, خلاص I will push for GE without discussion.
Actually, thing is that in the exam you don't have to become a hero. You just have to pass the exam. Okay. So even if you do it, even if we practically do it, we can do it. But thing is that in the exam, you don't, again, I use the word, you don't have to be hero. Tell the thing.
No, even in practical, I will refer to the obstetrician. This is not my decision.
Yes. Okay. So you will discuss with the surgeon how much time you have. If there is few minutes, or it is easily to position the patient or proceed, you will do. Otherwise, you will not take a risk. You will immediately intubate the patient by rapid sequence induction, and you will give GA. Okay, so the way which I am telling you will give you an approach for all the questions they ask. The general approach is like that. Whenever they are, and now I will come back to the patient. Now I will give you a scenario. A patient, known hypertensive and diabetic, presented for laparoscopic cholecystectomy. Okay, known hypertensive, known diabetic, 60 years old. I will write down the data. Okay, so who will answer?
$60-year-old.
Yes.
This one will answer, or can I answer?
Who wants to answer? Anyone else want to answer?
Yes, I want to answer.
Yes, please, Dr. Khalid.
Yes. We can take this scenario into pieces. First, the patient is going for elective surgery, so we have time for preoperative evaluation. Being diabetic means we have to go through her diabetic history, if she's insulin dependent or non-insulin dependent, and for the trials for diabetic complications, if there is any. And we have to make sure the diabetes is well controlled by diabetologist consultation. We should have hemoglobin A1C within the last 8 weeks, and normal RBF in the last figures. We have to make sure also about the oral hypoglycemic choice that she's on. If she's on metformin, that's a good choice, but should be stopped 48 hours before starting the operation, because it's associated with morbidities if within that period. We have to make sure on her admission to hospital that she's on running the insulin and on ongoing IV fluid. Best for her is D5 normal saline or half normal saline. Sorry, that's from the last thing before transfer to the OR. We have to make sure that her last RBS is within 60 to 300, not less than that, or they are more than that. That's from diabetic side. From the hypertensive side, we have to make sure about her control, if she's controlled or not, or uncontrolled. If she's controlled, we have to revise the drugs. If she's on AC inhibitor, it's better to be shifted to another. If she's on diuretic, it should be stopped and also shifted to another entity. If she's uncontrolled, we have to ask the cardiologist to adjust her medication. The preoperative. If her blood pressure is over 110, that's cut off point for which she can't proceed 2 weeks before the operation. Other than that, if the cardiologist should make evaluation for her condition too, using the ECG to make sure there is no signs of ischemia or from the diabetic history of her, or hypertensive disease of the heart, like hypertension. So after that, okay, give us more 10. Sorry for that. Yes. Okay. And just to my sentence. Sorry for that, for interruption.
No problem.
Okay. After that, being sure that she is controlled from the diabetic side and the hypertensive side, we should go through her also other comorbidities, possible comorbidities that may be there, like the standard evaluation, respiratory side, lab-wise, and everything is looking fine, we can proceed to the surgery. Then we can discuss the points regarding the laparoscopy itself. I mean, its considerations. If you want me to go through it, I'll go through it.
Yes, yes. Actually, and you know, Dr. Khalid, you have told everything perfectly. I will just amend only a few things, okay, which will make your answer even more programmed, and whatever they want to ask you, because as we discussed earlier, that they have little time, okay. So they want you to tell everything in a flash, okay. So I will tell you that same thing, because diabetic hypertensive will be there in the exam. So you can use the word that I will evaluate the patient on the basis of history, examination, and relevant investigation to see the microvascular and macrovascular complications of diabetes and hypertension leading to end organ damage in the form of CVA, in the form of peripheral vascular disease, in the form of ischemic heart disease, in the form of autonomic neuropathy. Okay, so my evaluation will be focusing to rule out the microvascular and macrovascular complication because of the long-standing hypertension and diabetes leading to end organ damage, which you will be seeing in the form of CVA, in the form of peripheral vascular disease, in the form of ischemic heart disease, in the form of heart failure because of chronic implication of this thing. So in this word, you have actually told everything, okay? Microvascular and macrovascular complications of hypertension and diabetes leading to end organ damage. And now you can say that I can focus whether the patient has any neurological problem, any signs of autonomic neuropathy in the form of postural hypotension, okay? Any signs of ischemic heart disease that I will be evaluating on the basis of functional capacity, any chest pain, any signs of heart failure, both right or left heart side failure in the form of any cough, dyspnea, PND, orthopnea, okay? This is detailed.
Yes.
If you tell in the first few words, you will be able to, and then you can say if there is any relevant history and any finding in examination, and if there are any major or intermediate predictors, okay, you will be going through the investigations and further evaluation in the form of ECG and exercise tolerance test or echo. If there is some risk factor, like for example, diabetes, which is controlled, is not a risk factor, okay? In diabetes becomes risk factor when it is insulin dependent, number one. Number two, it is leading to any ischemic heart disease in the form of stable or unstable angina, or there is some acute or recent MI or previous MI. This is the risk factor. Or because of ischemic heart disease or diabetes, is there, for example, there is a history of CVA, or there is history of TIA. That now it has become a risk factor. If you just recall the clinical risk factors that are called as intermediate risk factors, or the major cardiac predictors like active cardiac condition like acute or recent MI, decompensated heart failure, unstable angina, severe arrhythmias, or severe valvular heart diseases. Okay, so these are the major predictors. Then the clinical risk factors, in some books it is written intermediate predictors. These are history of CVA, stable angina, previous history of MI, insulin dependent diabetes mellitus, or for example this diabetes or hypertension has led to renal dysfunction with creatinine more than 2, or more than 176 micromole or more than 2 milligram per dl. Okay, so now that becomes a risk factor. So your focus in your answering will be that you will be looking at one of these things, any clinical sign, symptom, or investigations which is by which you can pick any clinical risk factor or any active cardiac condition. That will be your focus. Okay, because uncontrolled hypertension will have effect on all these systems. Okay, patient can have protein urea because of the microvascular complication in the kidneys. Patient can have some, like I give you a scenario, not in this patient. This patient is undergoing a surgery in prone position. Okay, and now this patient is diabetic and hypertensive. So you have to do the fundoscopy, because if you don't do the fundoscopy, you do make the patient in prone position. There were retinal problems preoperatively, and now after surgery, that problem has increased, and suddenly patient is not able to see, and they are catching your neck. That you did not give proper protection for the eye, and now patient has become blind. Am I right? So that's the reason of even doing the preoperative evaluation regarding the retinoscopy in a hypertensive or diabetic patient. You have to rule out, or you have to document if there is any. And how will you find? You will find according to the severity of the disease, according to the control of the blood pressure, and some concerns related to the medications. Like if patient is taking any diuretics, you will expect any electrolyte imbalance. If patient is taking AC inhibitors, you will expect hyperkalemia. You will expect some cough and respiratory symptoms. Okay. Similarly, if your patient is taking multi-drugs, you will expect exaggerated hypotensive response. If patient is taking AC inhibitors, there is not a recommendation, but some people say that if they are taking number of drugs, you can stop, you can skip the dose. Okay. But this is not a clear recommendation. You can either stop. If the patient is continuing, you have to control it. Okay. And this is the main focus on the preoperative evaluation. And then you will continue the medications. You will, general rule for diabetes will be that you will, of course, you will see the HbA1c like you told. And then you will, your aim will be long-acting medications should be converted into regular insulin. Okay, and according to the surgical stress, and according to the blood sugar control, and according to the NPO status post-operatively, you will target. And your main focus is to control the blood sugar with the range of 120 to 150 milligram. Maybe in the millimole, it will be around 7 to 10, less than 10 millimole. Or in a milligram per dl, your target is 120 to 150 milligram per dl. You because long acting, you can cause hypoglycemia, so you will try to convert into regular insulin. And another thing is that you have to check blood sugar half hourly to 1 hourly. This is another point. Preferable to give IV bolus or IV infusion. Infusion is the best. You can give IV bolus. Subcutaneous route is not very reliable, so it is better to give infusion or bolus. There are certain hospitals in which they prepare a bag in which there is insulin, there is dextrose, there are electrolytes, and they pasted blood levels and the rate of the insulin. Okay, so for example, they have pasted that if blood sugar is between this range to this range, you will give at this rate. If the blood sugar is between this range to this range, you will increase to this one or decrease to this one. Okay, so this is when they will or they are expecting this answer from you, that you will control the blood sugar in that way. That is maximum you will be asked. That long acting should be converted to regular, or short acting oral hypoglycemics should be stopped and converted to insulin, because you can control it accordingly. Your target blood sugar will be between 120 to 150, and you will control the insulin rate according to the stress of the surgery. Main concern is hypoglycemia, because hyperglycemia, yes, can cause any complications, but hypoglycemia is more dangerous. So you will be focusing on both hypoglycemia and hyperglycemia. Okay. And another point which is important in diabetic and hypertensive patient is that these patients, if with, for example, diabetic patient with autonomic neuropathy, you can say that this patient can have sudden hemodynamic response. Like if you give any induction agent, patient blood pressure can fall down significantly. So you have to use the titrated doses. And you can even say that if there is any doubt, you can have invasive arterial blood pressure monitoring if you have any doubt. Like if you have a patient who's telling history of syncope while standing, which is showing there is a significant postural hypotension. So you can use the word that maybe I would like to take invasive blood pressure monitoring. Okay, so that I have better control on the blood pressure and hemodynamics. Okay, so these are the important points. And you have to maintain the blood pressure in the preoperative range, because if you decrease the blood pressure more than 20 to 25%, because these patients will have altered cerebral autoregulation. Okay, so if you decrease the blood pressure more than the required or more than 20 to 25% of baseline, patient can have some cerebral problems. Okay, so because this will be important in surgeries where the surgeon is asking you to have hypotension. So it is better to have the preoperative readings as the baseline, and you will try not to reduce the blood pressure more than 20 to 25%. This will be an important point, like I told you about retinoscopy. Okay, so coming back, that these are the points which you will be focusing for diabetes and hypertension. And we have already discussed about laparoscopic surgery. So you can tell there are three for laparoscopy, because it's a very common, this will also be asked. So for laparoscopic points, I will tell you a very good way. Laparoscopic surgery, it has three important points. Number one, trocar insertion, because when they are inserting the trocar, it can cause any vascular hemorrhage, any injury to viscera, which can be very dangerous. Number one. Number two, after trocar insertion, when they are doing the pneumoperitoneum, if the depth of anesthesia is not good, there will be vagal response and patient can have sudden bradycardia. So it is advisable to increase the depth of anesthesia at that time. Okay. Number three step is that when they have completed the pneumoperitoneum, now CO2 starts absorbing. There is a decreased venous return. There is decreased FRC. There is chances of patient having VQ mismatch. And because of decrease in like blood pressure and cardiac output, there are some hemodynamic problems. And the CO2, which is absorbing, it is increasing the sympathetic response. Okay, so actually in normal patients, maybe they will tolerate it. But if the patient has some hemodynamic problem, like for example, mitral stenosis, or the patient is having any heart failure, that patient will have problem during laparoscopic surgery because of the hemodynamic stress. So these patients, you have to discuss with the surgeons whether laparoscopic surgery is better for them or open surgery is better for them. If there are some hemodynamic stress, they have to reduce the pressure so that this hemodynamic response is decreased. And you have to alter the ventilation accordingly, because whenever there is increased CO2, there is increased sympathetic response. So you have to alter the ventilation in that way. Another thing it will occur when they do the pneumoperitoneum is that the diaphragm moves up, so tube can become endobronchial. So I have to make sure that after they do the pneumoperitoneum, you have to confirm that your tube is still in the place and it's not endobronchial. Okay, so these are some points which you have to mention about the laparoscopic surgery, about the pressure, about the pneumoperitoneum, about the CO2 absorption, and in the start about the trocar insertion. So these are the same points which you can tell for any patient. Okay, so I hope you are clear. Am I right? Dr. Khalid, is it okay? Yes, Dr.
Yes, it is okay.
Anything you want to add?
Yes, I can borrow your sentence like which we make in pregnancy, that we say we have a geriatric patient which has anatomical and physiological change, which will modify my plan for anesthesia.
Yes, very good.
This can be start sentence.
In the form of
in the form of that, we have comorbidities like patient diabetic hypertensive or have cardiac problem. These patients have issue in drug metabolism, so I will titrate my doses according to this. Also, will check their the previous history of anesthesia, or they have cardiac problem, stenting, or valve replacement, or changing, or check the anticoagulant they are on it. Their drugs, يعني, or check their drugs.
Okay. What else? They have fixed cardiac output dependent on heart rate. Okay.
Yes, they have no response to fixed the cardiac, no response to hypotension like adults. There is no tachycardia. Also, there is
hypercarbic. The ventilatory response and baroreceptor responses are also blunt. Okay.
They have conduction defect because from fibrosis. I expect they have arrhythmias. They are fragile patients, so are they very sensitive to dehydration.
Difficult IV cannulation.
Yes.
Difficult intubation because difficult mask ventilation because of heat ampulus. Okay. And altered pharmacological responses like
the drugs which they have metabolism of renal or liver, they can be prolonged effect.
Yes. And as well as volume of distribution, body fat is decreased.
Decrease the volume of distribution, so we'll titrate our drugs don't give same dose like adult or one shot. We should titrate according to their hemodynamics.
Yes. So and difficulty in positioning, because these patients may have osteoarthritis and joint limitations. So this is the point which you have discussed. This you can tell in any geriatric patient. Altered physiological, pharmacological, and anatomical consideration leading in altered cardiovascular responses, respiratory responses, difficult positioning, difficult IV cannulation, more chances of post-operative cognitive dysfunction.
Cognitive dysfunction, yes.
Okay, more chances of delirium, more chances of for example, if patient is already have some comorbidities, that will be exaggerated. Okay, so you have to act accordingly. Similarly, like you see any surgery which comes. So now I'm just trying to because we are all like limited time left. Okay, so I just want to just revise what we have discussed. That we have tried to identify, because they will be asking you any scenario. So in that scenario, you have to give respect to the patient identity, demographics, his age, sex, and anything related specifically to that patient. Okay, so this will be point number 1. Point number 2 will be surgery. Any concerns or positioning or risk factor or whatever related to surgery. And the third thing will be according to the surgery the patient is being done. Okay, so in that way you will be able to chalk out that what specific points you need to tell in that scenario. Okay, and then because I'm left with few things which I want to tell you, it's few words about multimodal analgesia, because this will be you have to tell in every patient. So if, for example, any surgery we take, for example, if we take a laparotomy and you want to give a multimodal analgesia, on which factors you will decide what medications you need to give or what plan you will make for laparotomy. Yes.
Again, sir?
Yes.
Again, the
multimodal analgesia. You have to plan any
multimodal analgesia. We will go according to WHO step ladder. First, we will start with simple.
No, Dr. Zabir, you are missing a trick. This is not chronic pain. This is acute pain. So acute pain. You know, I will give you a funny example, so you will never forget the WHO step ladder for acute pain. if you have a fight with someone, you have to give a very strong push to the person, because if you slap you slow, he will slap you very hard. So this is the concept of acute pain management, that if you want to control the acute pain, start with the maximum. Give a big slap so that the pain does not give you anything. You start with the maximum and then you pull back. And the concept of chronic pains, WHO step ladder, is opposite. You start with the simple one and you then increase it. So the concept for multimodal analgesia for acute pain, that you will be giving all the medications which you can give according to the age, sex, presentation, any comorbidity, the type of surgery, whatever. Like, for example, paracetamol. Paracetamol is one of them. NSAID is one of them. Opioids is one of them. Then any regional block is one of them. Local infiltration. Then there are some specific adjuncts like ketamine infusion, lidocaine infusion, dexmedetomidine infusion. Okay, so these are the adjuncts. And I will just tell you that you always have to remember there are 4 steps of pain. 4 steps of pain which you have to cover whenever you are giving analgesia. Number 1 is transduction. Transduction. This is at the nociceptor level and from where the pain is started. Number 1. Number 2 is transmission. Transmission is through A delta fibers or C fibers, and it is traveling from there to from the site of the pain to the brain. From the A delta fibers, C fibers, they go to spinal cord, then they travel, they go to thalamus, and then from thalamus it go to the brain. So this is all transmission. Number 3 step is modulation. Modulation is just like control, increasing or decreasing, like the response which is increased or decreased. And the 4th thing is perception. Perception is in the brain. Okay, so you have to know that all the medication which you are giving act in either 4 of them: transduction, transmission, modulation, and perception. Transduction, like for example, if you are giving a local infiltration, it is blocking the receptors, the nociceptors. So there is no pain is being transduced or transmit. So it is blocking the transduction and transmission. Then you are giving NSAIDs. NSAIDs is anti-inflammatory. It is having effect on the all the prostaglandins which are being secreted. So it is reducing the modulation. It is reducing, like for example, there is a primary concept of primary hyperalgesia and secondary hyperalgesia in the form of inflammatory response which occurs after injury. Okay, so when you are giving NSAIDs, you are decreasing this response, which will decrease not only the transmission, it will decrease it will cause the peripheral modulation, that it will decrease the cause in response to the pain. Okay, so there will be decrease in the form of decreased inflammatory mediators. So these mediator release is being stopped by NSAIDs which you are giving. Any NSAID like ketorolac, like diclofenac, like anything. Okay, then the other thing will be opioids. Opioids which you are using, actually they are acting on modulation and perception. They have effect on spinal cord in the form of modulation, and they are acting on the brain, central nervous system, as perception. Then you use paracetamol. Paracetamol is acting on also on COX receptors, which are there for NSAIDs as well, but it is different COX receptors. These are COX-3 receptors. COX-3 receptors are in the central nervous system, and they are affecting the perception to the brain, the perception to the pain in the brain. Okay, so paracetamol has effect on pain in central nervous system by modifying the response to pain. Okay, and actually paracetamol also has antipyretic effect by its effect on hypothalamus. So fever is usually also the response to pain. So it is affecting as antipyretic as and also as analgesic, but it has no anti-inflammatory effect because it has no effect on COX-1 and COX-2 receptors, which are related mainly to the inflammatory response, and the NSAIDs which we give, they act on COX-1 and COX-2 receptors. Okay. So in among this, the concept of selective COX-2 receptors. So the actually COX-2 enzymes, COX-2 is involved mainly at the site of inflammation. Okay, so if you are giving COX-2, it is friendly to the stomach, because COX-1, when you give a lot, it is damaging the kidneys, it is damaging the stomach. So COX-2 are stomach friendly. Because COX-2 enzyme is acting mainly on the places of inflammation. Okay, so this is the concept of multimodal analgesia. Few only very important thing which you hear a lot is gate control theory. Gate control theory is through any electrical therapy or any medication which is modifying the pain by controlling the gate. There is a gate in spinal cord which closes the pain transmission through the spinal cord. Okay, and the concept is that whenever there is pain, we rub that place. When we rub the place, which actually we stimulate A beta fibers. Okay, so they close the gate in the spinal cord which is transmitting the pain. Okay, so same theory which we use generally whenever there is pain, we rub that area to decrease the pain sensitivity or pain perception. Okay, so at that time when we rub it, actually we decrease the pain by rubbing it, and actually what we are doing is A beta fibers are stimulated and they are closing the gate in the spinal cord which is supposed to transmit the pain to the spinal cord. The same concept is used in acupuncture. The same concept is used in TENS, transcutaneous electrical nerve stimulation. The same concept of gate control theory. Okay, and the same concept is being used in some medication which release substance P. It is also through the gate control theory. Okay, and in the medication which we use for usually we are using in chronic pain, antidepressant, anti-epileptics, they are actually acting on central nervous system and they are also changing the pain perception. So paracetamol, opioids, and antidepressant, antiplatelets, they are acting on perception. The medication which we usually using, paracetamol, it is acting on perception. NSAIDs, it is acting on usually on it is also modulating, it is also decreasing the transmission. Okay, and it is acting as anti-inflammatory. And some medications which are left are lidocaine. Lidocaine is actually acting as membrane stabilizing, and it is decreasing the sympathetic response to the pain. Similar is dexmedetomidine, Presidex, which we use. Actually, it is alpha-1 agonist. Alpha-2 agonist. It is centrally acting alpha-2 agonist, and it is also decreasing the sympathetic response to the pain by decreasing the heart rate, decreasing the blood pressure. And it is acting presynaptic. It is alpha-2 agonist, and it is inhibiting the release of sympathetic system, discharge of sympathetic system. Ketamine is being used as an analgesic, and it is acting on thalamus, on NMDA receptors, which is also controlling the response to the, it is also controlling the modulation. So it is decreasing the response to the pain. That's why ketamine is like a medicine which is decreasing the pain in the form that patient is not able to feel it. Okay, it is causing dissociative anesthesia. So these are like I just told you the basic concept of pain management. So when you are telling any multimodal anesthesia plan, you can take few medications from each of the group. Okay, like you can have local infiltration, or you can have any compartment block in the form of TAP block, or this quadratus lumborum block, or subcostal block, rectus sheath block, or if you are going up, you can have PAX block, or you can have erector spiny block. This is all are compartment blocks, or central neuraxial block in the form of spinal or epidural. Okay, then you can have any peripheral nerve block in the form of, in the lower limb, you can give femoral block or sciatic block, sciatic nerve block, and in upper limb you are giving brachial plexus block at different sites according to the need and requirement of the surgery. But the main concept you should be knowing. And then you can add paracetamol, NSAIDs, dexmedetomidine, opioid, different opioids according to their pharmacology, long acting, short acting, whatever you need, whatever the patient is, and you can make a combination out of these different analgesics which I have told you. Okay, so this is the concept you should be knowing. Like if I just try to summarize everything, we do anesthesia planning, or whatever we are discussing is actually anesthesia planning. On the basis of history, examination, and relevant investigation, we chalk out the risk factors. This is true for any patient. This is true for any anesthesia management. Okay, so whenever they give you a data, you have to just scan in your mind what are the risk factors in it, and what are the problems which you will be facing in this patient regarding. Yes, one more very important thing which I missed is monitoring. Okay, so whenever you are telling any patient, any scenario, please chalk out whether any special investigation is needed. Like, for example, you will use the word, in addition to standard 1, standard 2 monitoring, I will be doing the invasive blood pressure monitoring because this patient has autonomic neuropathy and there can be swings of blood pressure. This I'm giving you example. In addition to standard 1, standard 2 monitoring, patient will having neurophysiological monitoring because they are doing any neurosurgery or any spine surgery in which there are chances of problems with the spinal cord, or so they want to monitor the somatosensory and motor evoked potentials. Okay, or if they are doing any neurosurgery in which they are doing the neuromonitoring for the sake of involvement of nervous system. So they are asking you to give give anesthesia in the way which does not affect the evoked potentials. Like this is a topic which couldn't touch is BIS, bispectral index, by which we monitor the depth of the anesthesia, and sensory and motor evoked potentials. All of them are affected by these evoked potential. They are affected by inhalational agents. They are affected by muscle blockers. Okay, they are affected by nitrous oxide. So whenever they are doing neurophysiology monitoring, they would ask you to give TIVA, total intravenous anesthesia. So you have to chalk it out that any specific monitoring, and specific monitoring can be anyone, but according to neuromonitoring, I have told you the few reasons. They also do the neuromonitoring in aortic aneurysm surgery, in which they do the clamping and cross clamping because it is also affecting the spinal cord. They are doing in some other spine surgeries or some other surgeries in which they are doing one is neuromonitoring and one is nerve monitoring. Nerve monitoring, I told you regarding facial nerve, or they are doing it for recurrent laryngeal nerve in case of thyroid surgery, so you don't have to give the muscle relaxant. When they are doing the neuromonitoring, they will preferably, they would ask you to give, don't give any medication which change the latency and amplitude. Latency and amplitude of the evoked potentials. Latency is the time after which the effect comes, and amplitude is the strength or power of the response which is coming. So these are the two concepts which you can use the word. If some discussion comes to the use of evoked potentials, you just have to mention that you have to avoid the medications which alter the latency and amplitude of the evoked potentials. Okay, so this is related to neuromonitoring. So in any patient, when you make a plan about the positioning, plan about the monitoring, plan about the preoperative investigations, and why you want to do, what information which you want to get from any investigation. Okay, like for example, ECG, you can mention, I will just try to tell as much as possible. For ECG, you have to tell about rate, rhythm, axis, hypertrophy, ischemia infarction, or any change in because of electrolytes, or any change in morphology of P waves, PR interval, and QRS. Usually these are the things which you are noticing in the ECG. So any problem in the rate, rhythm, axis, hypertrophy, ischemia infarction, any electrolyte imbalance, any problem in the P wave, PR interval, and QRS complex, QT interval, like any blocks. So ECG, whatever you are doing ECG to rule out any of these things. For echo, I will try to give you a very good word which you can use for echo. for echo, you want to see the systolic and diastolic function. Systolic function in the form of ejection fraction and diastolic function in the form of diastolic relaxation. Systolic function in the form of ejection fraction and diastolic dysfunction in the form of diastolic relaxation. Because in hypertensive patients, the initial sign which we get in echo is not the systolic dysfunction. It is the diastolic dysfunction. Because of chronic hypertension, there is hypertrophy. So it is affecting the diastolic function, and it is causing the impaired relaxation. Okay. So it is which you have to see in echo. This is one thing. Then you have to see the chamber size, chamber pressures, any clots in it. Then you have to see the segmental wall motion abnormality, which will be telling you about the ischemia or infarction. If there is a segmental wall motion abnormality, it's an early sign of any ischemia. Then it will resulting in either hypokinesia or akinesia, according to the level of ischemia and infarction which has occurred. So segmental wall motion abnormalities, hypokinesia and akinesia, according to the grades of ischemia or infarction which is occurring. Then the valve, according to valve, we have to see the valve size, we have to see the transvalvular pressure gradient, and you have to see regurgitant fraction. You have to see the valve size, you have to see the transvalvular pressure gradient, and you have to see the regurgitant fraction. This is for echo. If anyone asks you anything about echo, you just chalk out. You can use these words that if I want to do echo, I want to see these things. Maybe in your scenario, there will be not only few things, like if you are telling the reason for echo in ischemic heart disease, you can only tell that I have to see the degree of ischemia and infarction or failure which is occurring in these patients in the form of any segmental wall motion abnormality or hypokinesia, akinesia, or systolic dysfunction in the form of ejection fraction and diastolic dysfunction in the form of impaired diastolic relaxation. Okay, and then some more thing about echo is the pulmonary hypertension. You can just have an idea about any possible pulmonary hypertension. And last but not the least is very important is the vena cava compressibility, which you can see through echo, and it will tell you whether the patient is having a overload or patient is fluid responsive. This is actually the information which you can get from echo. For CBC, whenever you are telling about CBC, you have to tell I have to see the hemoglobin, I have to see the WBC count, and I have to see the platelets, like in any involvement of any infection, to see the hemoglobin status and platelet if you are giving any regional anesthesia. Electrolyte imbalance, it can be primarily because of any neurological problem, any endocrine problem, okay, or because of any medication the patient is taking. Usually the electrolytes which you are seeing is sodium, potassium, usually sodium, potassium, calcium, magnesium, usually which we are focusing. So sodium will have problem with the neurological, or if patient is having any problem with aldosterone and ADH, so it will be affecting sodium. And if, for example, similarly potassium, it will be affecting the heart. So whenever there is problem in potassium, the effect will be in the ECG or in the neuromuscular weakness. Okay. Similar is true for calcium and magnesium. But you just have to focus, and you should be knowing the reason for which you are doing the electrolytes. Similar is for renal function or liver function. If any medication or any condition in which liver function is disturbed, either its synthetic function or its hepatocellular function or its obstructive function. Like if there is obstruction, there are certain changes like alkaline phosphatase or bilirubin will be increased. Okay. If there is synthetic function, it will be checked by individual factor levels, or it will be through albumin or PT-INR. This will be telling you the synthetic function. And if there is any hepatocellular damage, it will be you will have raised ALT, AST, or gamma GT. Okay. So similar is for renal function. This function you will be seeing at the renal urine complete to see any ketones, any RBCs, any sugar, any proteins. And you will be seeing at the creatinine, which will be telling you the it is depicting the function of the kidneys. So these are the possible investigations which you do. Other than that are the specific investigation for specific conditions, like you are doing any thyroid surgery, you are focusing on the thyroid profile. If you are doing pheochromocytoma, you are doing the either the catecholamines level in the blood or the catecholamines metabolites in the kidneys, or you are doing anything to locate presence of this adrenal tumor. Okay. Invest and very important evaluation I forgot to discuss is airway. So airway, whenever someone wants to evaluate about the airway, you remember one thing, you have to tell something about the history, something about the points in the examination, and some points in the investigation. In the history, or this is one thing. The other thing that you have to focus on three things: difficult mask ventilation, difficult laryngoscopy, and difficult intubation. These difficult laryngoscopy and difficult intubation almost are the same thing, but there are few small differences in it. Mask ventilation or any points in the history, you will be taking history about the snoring, artificial dentures, history of like airway obstruction, any previous history of difficult airway in previous surgeries, or any history of chemotherapy, radiotherapy, which will be distorting, or any specific disease, like for example, rheumatoid arthritis, ankylosing spondylitis, even diabetes. Diabetes, they have glycosylation of joints and leading to difficult laryngoscopy and difficult intubation. Okay. Acromegaly, they have difficult intubation. They don't have difficult mask ventilation, but they have difficult intubation. Okay. Similarly, rheumatoid arthritis involving atlantoaxial subluxation and TM joint ankylosis. So there is difficulty in mouth opening and difficulty in positioning the patient for adequate laryngoscopy. Okay. So these points you have to ask in the history, like snoring, nasal blockage, nasal pit, and then the points I have told you, any history of neck pain, any previous history. And then in the examination, you are doing some things to see the mouth opening, some things to see the jaw movement, some things to see the distances and the neck movements. Okay. And your examination is focusing on malampatti or whatever, but actually you are seeing whether trachea is midline, trachea is compressed, okay, and you are able to have the adequate mouth opening. And the three angles which you straighten, oral angle, pharyngeal angle, and the laryngeal angle, are you able to straighten the angle or not? Are you able to ventilate the patient easily or not? If, for example, patient is edentulous or elderly or has beard or has any problem which is compressing any, like for example, any thyroid mass or any thing, any history which is compressing the trachea, so that you will be focusing. So airway examination is focusing on these things which I have told you. But the rest of you things you know, so I don't need to tell you, but this is the main focus which should be in your mind. Difficult mask ventilation, difficult intubation, difficult laryngoscopy, and difficult intubation. Like for example, if you are not able to pass the tube despite you are able to see it, because it is because of some factors which is creating obstruction in it. Okay. So like if you are not able to open the mouth, as occurs in TM joint ankylosis, you are not able to do the laryngoscopy at all, because you cannot open the mouth. In that scenario, you have to go for awake fiber optic. Okay. So like airway management is very important, because one scenario always comes. So you have to consider these points which I have told you. And when you have any doubt, go for awake fiber optic. In this exam, you should have low threshold for awake fiber optic. And when you use the word awake fiber optic, they will be asking you how to do it. So for that thing, you should be knowing that which nerves you want to block. So you have to block not only the nose, also the oral cavity and the pharynx and up till the larynx. So you should be knowing the nerve supply of each area. Like you should be knowing what is supplying the tongue, what is supplying the pharynx, which is supplying the nasal cavity, because usually you can do either nasal or oral. Nasal is easier as compared to oral because of the there will be less chances of damaging this fiber optic. Okay, but you can be asked for either of them. So you have to tell you should be knowing the nerve individual nerves, and practically, because usually the answer we should be giving is the lidocaine nebulization or lidocaine gargles, and after that spray as you go, because the invasive blocks which you can give for superior laryngeal nerve or recurrent laryngeal nerve in the form of this transtracheal injection, actually these are practically not that much use as compared to gargles, nebulization, and spray as you go. So practically you can say the same thing, but you use the word that I will be calculating the safe dose, because relatively higher dose will be allowed for lidocaine, like it is around 9 up to 9 milligram per kg. And then they can ask you that how much dose in one spray. So it is actually, if it is, whether it is 4% or 10%, usually you can say it can vary according to different preparation, but usually 1 ml is 10 spray. I repeat, 1 ml is usually 10 spray. So if it is 10%, so one spray will be 10 milligram, because 1 ml will be 100. So if 1 ml, there are 10 sprays, so 100 divided by 10 milligram per spray. So according to the milligrams per spray, you can calculate according to the safe dose how much you can give. And another point you will be saying that when you are telling the patient, you have to explain the procedure. And if he is doing the gargles or even spray, you are doing the sprays, you have to tell that you don't have to swallow it. You have to try to keep it in the oral cavity or in the throat and then spit it out, so that you are avoiding the chances of absorption. Okay. And another thing is that if it is, for example, 4%, it will be 4 milligram per spray. Accordingly, you can manage. So this is what they will be asked about difficult airway. You can bring this difficult airway and awake fiber optic in case of difficult thyroid, difficult like any other conditions in which you have any doubt. Okay, so you will not take a chance and you will say rheumatoid arthritis and chalazion spondylitis, or the pediatric conditions in which you are anticipating this thing. And the difficult airway drill you should be telling in every patient. If you have any doubt, you say you will have adequate size of nasopharyngeal airways, oropharyngeal airways, LMA, bougies, fiber optic, rigid bronchoscope. Even if you are dealing a patient with thyroid, you should be saying that I will keep ENT surgeon on board with preparation to do tracheostomy and even rigid bronchoscope. Why? If there is enlarged thyroid, you will not even be able to do the tracheostomy. And maybe if patient is collapsing because of the airway collapsed, you can use rigid bronchoscope to elevate the obstruction, or you can do the reverse Salic maneuver. Reverse Salic maneuver is actually lifting the enlarged thyroid to relieve the obstruction. Lifting the enlarged thyroid to relieve the obstruction, or the ENT surgeon can do the rigid bronchoscopy to relieve the obstruction. And if, for example, it also failed, then another option is to do, as I have told you, reverse Salic maneuver, or you can make the patient in lateral position. Because if the cause of you are unable to ventilate the patient because of the tracheomalacia.
Doctor, one more question.
Yes.
About this issue, because we have one in ER, there is a huge thyroid mass, maybe malignant, and patient difficult intubation. So in this way, surgical way, it is not accessible.
Okay.
So what should be our plan it will be awake, awake fiber optic?
Yes, there are different ways to answer this question, but I tell you something. because the good thing is that you don't have to perform it. Okay, you just have to tell them the safe possible way. So the thing which you can say is that you will, if the facility for awake fiber optic is not there, you will preferably refer the patient to the place where there is awake fiber optic. This is number one. If
patient was Disney.
I'm sorry?
Patient was Disney, about to collapse, obstructed airway.
In that scenario, you see, you have to manage accordingly. You can have a ramp position. Ramp position is called as rapid airway management position. This you can say in either in obstetric patients or in pregnant patient, because in that condition you are elevating the external auditory meatus, like you are increasing the level of head in the way that you are bringing the external auditory meatus at the level of the sternum. It's called as angle of Louis. Okay, you are bringing the angle of Louis to the level of like you are bringing the external auditory meatus at the level of angle of Louis. So this is decreasing the problem. Okay, so this is one thing you can say. If it is obstructing, you can tell, as I told you, about rigid bronchoscope, about patient making the patient unilateral, or this reverse Salic maneuver, which I told you. In this reverse Salic maneuver, you can lift the compression which is there. Okay, these are the scenarios in which you are not able to do the tracheostomy even. Okay. And in the induction, if for example,
Dr. Said, excuse me, boss. Yes. If there is a role for the ECMO at this scenario, preoperative or at the ER, ECMO.
You see, if you try to hit your foot with a big hammer, it's like that. Unless they push you. Like if, for example, they have given you a scenario, you will try to refer. If you are facing it in that time, because for generation of ECMO in emergency, it's not possible. Yes, preoperatively, if as you're told, that it will be a multidisciplinary team who will be deciding it. Dr. Amjad, can I request you to close the camera? Your camera is on. If you can just close the camera. Dr. Amjad, can you close the camera? Yes, thank you. So, like, you understand my point, Dr. Ahmed? So, like, don't try. Yes. Dr. Amjad, your camera is again on. So you don't, Dr. Ahmed, don't bring this point from your side unless they push you. Okay? Because if you tell in the Saudi exam this thing, they can damage you very badly. Because if they start asking you about ECMO, believe me, it will be a very difficult time for you, because it's not an easy question to answer unless they push you. Because there are only in real time scenario, there is only one condition in which you put the patient preoperatively to ECMO. What is that condition? They can ask you in the actually this is in pediatric. Which is that scenario? Which is that condition? Huh?
Tracheoesophageal fistula.
Not tracheoesophageal fistula, congenital diaphragmatic
hernia.
Yes, congenital diaphragmatic hernia. Okay. So try to make it simple.
So I'm brief, my sir, if because actually we face this in ER, huge thyroid goiter, so there is no mass, there is no way for surgical. So it will be rigid bronchoscope or
lateral position or reverse Salic maneuver.
Ramp position.
Yes, you see, reverse Salic maneuver, actually reverse Salic maneuver is not written in every book. So try to explain if they are asking you what is reverse Salic maneuver. So if you don't want to tell the name of reverse Salic maneuver, you can say that if it is a large thyroid which is compressing and you can see the swelling, you can lift the swelling up with the hands in the way to reduce the obstruction, or you can make the patient in lateral position, or you can make the position in ramp position, because all of this will help in doing the mask ventilation. Okay.
Then I can use video laryngoscope.
Video laryngoscope, glidoscope, whatever scope you want to say. Okay.
Yes.
And another way, if you don't have the facility for awake fiber optic, or the patient is refusing, another way which will be a better answer, that you will make a ramp position, you will do the pre-oxygenation, and you will make the patient in spontaneous ventilation and try to make the depth of anesthesia, and then you do the check laryngoscopy after giving like a small dose of lidocaine or very small dose of propofol, just to see the vocal cords. And if you are able to visualize the vocal cords, then you can give the muscle relaxant. This is another approach which you can tell in cases of difficult airway, in which there is no facility for awake fiber optic, and you cannot refer the patient, or you face it in emergency. So this will be and this scenario, you will tell also that there will be chances of aspiration. Okay. But the ramp position, will minimize a little bit, because it will be this one a little against gravity.
And another issue, you have one burn patient. She has a scar. She is difficult intubation. After 3 trials of fiber optics, there is edema. Patient start to desaturate.
Okay.
So the next step will be surgical airway. What's your preference?
I'm really sorry, I missed your question from the start. Can you repeat it?
Patient is burn. She has a scar, limited mouth opening. So we prepare for fiber optic. After 3 trials, there is edema, desaturate. What's your next?
Of course, you will go for cricotherapy. You will go for cricotherapy if you are not able to ventilate and you are not able to intubate.
Needle cricothyroidotomy, or we should inform ENT surgery from start to be attended?
Yes, you see, that's why I'm telling you that if you have even a doubt, even if you are doing awake fiber optic, you can say that if they fail, you should have a backup plan. Okay. So you in any surgery, when there is any problem, if you say that I will keep ENT people on board for either rigid bronchoscopy or tracheostomy, it will not be a wrong answer. Okay. So it is better to save your neck in the exam by saying this thing. Okay. So because the similar to in the airway, they can ask you that, for example, if there is a patient with difficult airway and a patient is having emergency cesarean section. Okay. So if you are not able to intubate and you are able to have LMA, because in emergency you have to proceed, like a fetal distress, you have to proceed, and like you can try for this one intubation through intubating LMA if you have placed it. Otherwise, you will proceed in the same. But if it is any elective surgery, okay, you will not proceed the surgery. You will awaken the patient. This is what you have to differentiate. Okay, in any emergency surgery in which you don't have any other option, you will proceed. Otherwise, you will awaken the patient. Okay, and go for regional if possible. Okay. So this is what you have to tell about. And there are certain pediatric scenarios which they can ask you. So I think, you see, we have taken around 2 hours. I hope I have been able to help you out and clear some of the confusions. I am available all the time. You can ask any question anytime. Actually, I am doing this daily in my native language, because I don't find much of the people, if you people are interested, because I can do it for everyone. Because in our group there are around 4,000 people on board with me. Okay, and they are in different stages of their career. Okay, and there are some residents, there are some consultants, there are people who are professor level in their home country, and there are people who are like appear in the exam. So I am available for all of them. This is my passion, and I'm trying to just fulfill my passion as much as as possible. Okay, but bottom line, remember one thing.
Just
yes,
you can for us contact number so we can arrange through WhatsApp like this or another thing.
Yeah, you see, I will just drop my WhatsApp number. If someone has don't have my WhatsApp number, just note down this number. And thing is that any topic you want to arrange, I will be very happy. You will like you can listen to the recording. I will share. And thing is that I will tell you that I have put it on a YouTube channel. Okay, so you can subscribe to that channel as well. Another thing is that some people don't know my name. I will be very happy to tell my name, but actually I tell you something that I'm doing this out of my passion. I don't have any interest, any other thing in my mind. Okay, but because I want to help everyone, I have made a Google Drive link. I can share that link as well. All of you can note down my number. I have sent in the chat box. When you will note it down, I will finish the meeting. Okay, so another thing is that whosoever wants to discuss any topic, just feel free to drop a message and I will try to answer all of you. Okay, because I have passed through all these phases. I have done basically, I'm trained from Pakistan. I have done my training in Pakistan. And then I was, before finishing my exam, I was in Saudi Arabia in 2011. So I worked for some time in Ministry of Health, Jizan. It was a very difficult time for me. I had not passed my exam and I was struggling with my exam. And actually, then I got job in National Guards, Riyadh. I worked 2 years in cardiac anesthesia. And in between, I finished my exam, it's a fellowship exam. It's called as FCPS, Fellow College of Physicians and Surgeons, Pakistan. It's just like comparable to the Saudi board or in the MD program of Egypt or Jordanian board or Arab board. So it is comparable to that one. We have recognition to the Royal College of Anesthesia in UK and also the College of Anesthesia in Ireland. So after finishing this exam, I got job in King Faisal Specialist Hospital and Research Center, which is the #1 center in the whole Gulf, but majority of people know about it. It was my luck. I worked there in 3.5 years. I worked there in transplant anesthesia. And later on in between, because that was the wonderful time of my life, and I have enough time, enough money to spend it on my studies. So I did a fellowship of College of Anesthetists Ireland, that is FCAI, Fellow College of Anesthetists Ireland. I did European Diploma in Anesthesia and ICU. Majority of people know about it. Then I did European Diploma in Regional Anesthesia. This is also Regional Anesthesia Diploma. And then I did another French Diploma, University Diploma, which was programmed in Dubai. Okay, so after that I tried to go back to Pakistan, but I couldn't settle. And then I came back and I became consultant in a private hospital. I worked for 1 year in a private hospital. Then finally I got job at King Saud Medical City. This is Shamisi Hospital. This is one of the oldest and biggest tertiary center in Riyadh. So since 1 year, actually, today is my first anniversary at King Saud Medical City. It's been 1 year here. So that's my story. This WhatsApp group, I started with few of the people with whom I was studying back in 2011, 2012. And gradually, it started growing the numbers. And now it's been more than 4,000 people. Okay. So this is my story. This is my introduction. Okay. So before that, I never used this Zoom meeting. And around 6 months ago, in the Corona season, when I finally developed Corona, I had enough time to sit at home, and I just started this Zoom meetings. And lately, I put everything on the YouTube channel. Unfortunately, for non-Urdu Hindi speakers, at the moment, there is not much But in coming times, if I got this impulse, some of the people who are interested, we can have these discussions in purely in English, and like I can increase the people who can get benefit. Okay. So because I have passed through this stage of exams, and the anxiety and the tension which we face is, believe me, that unfortunately the people when pass the exam, they run away and they don't participate and they don't care. But if we just think the problem and the misery and the anxiety and the tension which we face when we were in the exam, believe me, we will try to help others. That's my message to all of you, that try to help anyone, everyone, everywhere, anywhere. Well, I'm using whatever is coming in my mind at the moment. Please try to help others, because the biggest advantage which you will get through this effort, that you will be in touch with the studies. And after passing last academic exam in 2017, if I'm able to speak out after 4.5 years, believe me, this baraka is only because I am in touch with this with teaching at my place. So this is my suggestion, advice, request to everyone to help others, because I passed through a very pathetic time and I was not able to pass my exam back in Pakistan. I was very young, 10 years ago, and I had so much anxiety, believe me, that I had started arrhythmias and I had Holter and I had beta blockers for around 1.5 years. And the last dose of beta blocker I took on the day when I passed my exam. I never took beta blockers after that. So I know the anxiety, the problem, and actually whole of the family is suffering. Whole of the family is suffering because of the exams and everything. So this is my request. So thanks a lot for your presence. I will share the recording to everyone. If anyone wants to ask any question, any comment, any suggestion, you are welcome. Okay. If you can, I will share the Google Drive link. It has all the articles, books, and helping material arranged. And we will have another session. We can have another session whenever you want. Okay. We can have next session on coming Friday. Okay. You can send me any queries and we will arrange. Okay. Okay. Bye bye. Thank you, everyone. And my message, please spread the message to everyone. Okay. Thank you. Bye bye. Let me share you the, just a second. I will just share you the link to my channel.
Also YouTube channel, yes, YouTube channel.
Actually, this will be the first lecture in English, okay? Because before I was recording it in my native language, but you can follow the channel. Just let me share it. Just a second, please. Okay, can you see the link? All of you can copy the link from here. Just let me share one more thing. I have this on actually a Facebook page as well, because before I had this Facebook page only, and then later on the WhatsApp group grew. Okay, but now I am not very active in Facebook actually. And this is the, please copy this Google Drive link as well, because majority of the people are on WhatsApp. So my suggestion is that if any one of you is not on the WhatsApp, just send me a message with your name and place. I will add you to the WhatsApp group. And my message, please, I request all of you, please spread the message to everyone. My request and I don't want anything in return, but if I am able to spread this message that you have to help others at your workplace, whosoever is stuck in exam and whosoever wants to progress in the career, okay, I will be very happy to guide them. Actually, I would like to in next session we will discuss something about the career progression and career counseling. That if someone wants to progress in his or her career, I will be very happy to guide. Okay, but in between, if you have any question, you are free to ask. Okay, all of you. I will stop the recording, but you can note down the links and for some time. Okay.